So what happens to that group of 40 to 45? These new guidelines that are changing the whole spectrum of what we're going to be doing, what percent of women will fall into that? And I know certainly in prostate cancer, when you have young men coming with the disease, it's probably very similar in women also. The cancer is a lot more aggressive. It's a higher risk. And a lot of times they don't behave the same way as when you catch them later on. So what percent of people we're going to be missing in between that 40 to 45-year-old based on the new guidelines?
All right, and this is also both simple and complex in understanding. So first of all, the way the American Cancer Society is reading the statistics, it's a mixture of cancers that are being picked up at screening, mammography, for women in their 40s versus clinical presentations of, say, a lump that someone's feeling or worse, okay, in terms of how involved it is in the breast. And so what their data is showing is that women 40 to 44 comprise about 6% of the cancer incidence. But you know what? That data is mixed. You know, a lot of women, even if they're aiming to come in at age 40, they're not coming in at 40 right away, and that's okay, right? We're living our busy lives. So it's not necessarily a reflection of intention. So some of those cancers that are that we're finding on screening, well, obviously we see it when we see them, not necessarily when it was definitely present. So what they're saying is that 40 to 44 is a time when they support screening, but you got to know the potential downsides. And what they mean by downsides, what everyone's talking about with the, quote, harms and the risks of screening are the things that are being called, quote, false positives, the, quote, anxiety, all kinds of things that people have to understand really are potential part of any type of screening test, right? Even vascular ultrasound, et cetera, everything. But this really, really gets a lot of press. You know, understandably, it's a high-profile test. It applies to everyone. There are lots of reasons why we talk about breast cancer screening more than anything else.
Do you think costs have something to do with this or not?
Everyone says no, but you always have to wonder. Because when it comes to insurance decision-making, it's going to be the lowest common denominator that they would prefer, right? So we can sort of understand that, too, from a practical standpoint. But when it comes to costs in terms of other ways that people are referring to as a reason not to screen, it's a little bit of a fallacy to think that just by not screening 40 to 44, you're doing away entirely with false positives, right? And, quote, unnecessary biopsies. And besides, all these terms are really retrospective. How do you really even know what's going to be cancer and what's not when there's such overlap between imaging findings that fall into various categories? So it's us figuring things out as we go. And if we see women only in 45 and older, then a lot of those so-called false positives, meaning findings that are legitimate, mimicry, whatever it might be, are just going to be shifted to whenever we see them when they do come in.
And by the time they come in, they may be more advanced disease that may require...
Potentially. Exactly. And thank you for making that point, because it's potential, right?
Yeah.
All of this that we're talking about is relative risk, relative incidence, relative this, that, and the other. There's nothing that's 100% guaranteed. But what I can tell you is that those of us who really are experts in this, and I can only say this not because I'm talking about me, but as us as a field who really know this well, we screen annual starting at 40 and go for as long as we're in good health, because you just don't know who's going to exactly get breast cancer.
So you're not going to change your guidelines based on what just came down the pipeline?
We're not. And you know what's interesting is that the way ACS has written their guidelines with this wiggle room for 40 to 44 and then 55 and older going annually, it's to allow this personal decision-making, the so-called discussion that's supposed to happen. How is that supposed to magically happen reliably when there are a lot of women who aren't seeing doctors, and their doctors might be going by the U.S. Preventive Service Task Force guidelines? You see how there are lots of potential pitfalls here, so even more room for women, and actually compelling need for women themselves to be self-advocating, to become aware. Their own physical exam, more self-awareness about this, because you realize the clinical breast exam has also been undermined here. Not dismissed entirely, but undermined with the language of it. So there are lots of ways in which it's more important for women to be aware. And this is a golden opportunity and actually a major compelling need for organizations like Society of Breast Imaging, ACOG, but especially Society of Breast Imaging and American College of Radiology, to do what they're doing now, because as a mature, robust, full-bodied institution, we have a voice and really a platform to stand on, and that's what ACS wants. They want the other organizations to step up.